Welcome to AETCM, the emergency medicine channel. Yes, we all know we are in the series of endocrine emergency. Last part we discussed regarding the hypothyroidism. So in this presentation, I want to explain regarding the hyperthyroidism. So this anatomical note and all we discussed in the hypothyroidism itself. So how it will regulate normal level, and then thyroid disorder wise in hypothyroidism we discussed regarding the Hashimoto's disease, myxedema, coma, cretinism. In hyperthyroidism, main area of our focus is in Graves' disease, and then most important thyrotoxicosis or thyroid storm. So again, before that, what is meant by hyperthyroidism? So hyperthyroidism in the sense there is a excessive secretion or circulating thyroid hormone. So that is called the hyperthyroidism. So again, we know regarding the function of thyroid gland. So there will that will regulate your metabolism, and then that will regulate or that will aid in the action of growth and developmental, and then again that will regulate the heart rate and then respiratory rate. Again it have action in the thermoregulation, it have action in your calcium metabolism. So those are the various action. In hyperthyroidism, what it will happen, everything will get hike, means heart rate will go high, respiratory rate will go high, and then metabolism will go high, and then again the growth and developmental changes will be there. Mean the same time calcium level, if the calcitonin level increase means calcium level also will increase. So everything will go high because of the higher thyroid level in the body. So that is metabolic related emergency. What are the causes? So same like your hypothyroidism, here also we are dividing into primary hyperthyroidism, secondary hyperthyroidism. Primary in the sense, so there will be a problem or pathology will be in a thyroid itself. Secondary in the sense, there is a extra thyroid causes, means you have a intact or good thyroid function, but the problem will be in your pituitary gland or hypothalamus gland. So first thing we'll see the primary hyperthyroidism, means that is called the thyrotoxicosis, the other name for the primary hyperthyroidism. So here the one important first thing is the Graves' disease. So again in hypothyroidism itself we explained regarding the Graves' disease. So it is one of the autoimmune condition. So in your TSH receptor, your body will create some antibody, auto antibody that will go and attach your TSH receptor that present in your thyroid gland. So if the stimulant it's attached, means your thyroid will secrete the or your thyroid will secrete the hormone. So there will be increased T3 and then T4 level. So that is the reason, there is the thing called the Graves' disease. So it is one of the autoimmune disease. Okay, your body will create some auto antibody that will go and attach your TSH receptor. Thereby your thyroid gland, because of the stimulation, it will secrete the more amount of T3 and then T4. So that is called the Graves' disease. If you not treated the condition, or if the disease is, or if the Graves' disease is longing for some time, means then from hyperthyroidism the body will enter into the other condition, that is hypothyroidism, that is called the Hashimoto's disease. Okay, so and then this is the first cause. Second thing, if we have any thyroid carcinoma, means because of the increased surface area we will get again more and more secretion. Iodine excess, so again we told iodine is one of the key factor that will take a role in the thyroid hormone secretion or thyroid hormone formation. If we have a more amount of iodine, means there is a more amount of thyroid hormone. Secondary in the sense, again the problem will be in a extra thyroid related, either the problem will be in a TRH, so there is a TRH secreting tumor, or there will be a problem in the TSH related. If you have any pituitary adenoma, means there it can cause the secondary hyperthyroidism. So Graves' disease already we explained, it is a autoimmune disease. Thyroid storm or thyrotoxicosis. So the extreme state of thyrotoxicosis is a thyroid storm. It is one of the higher metabolic emergency related condition. So here it will, so again the symptoms everything will be same. So you will get a tachycardia will be there, you will get a increased respiratory rate will be there, there will be increase in metabolism growth related, there will be a diarrhea related things because of the increased gut mobility. So those are the things. The clinical features, whatever we are seeing in the hyperthyroidism, the same thing will arise in the thyroid storm, but it will be in a more aggressive manner. Okay. So again, causes wise, causes for the thyroid storm, thyroid carcinoma, the same thing, TSH secreting pituitary adenoma, diabetic ketoacidosis, trauma related things, myocardial infarction. So these are the stress factors. So in the time of stress, body will raise a request to your pituitary gland. So the body will tell us, I am in the stress, I want a more amount of thyroid hormone. So because of that stress, body will secrete more amount of thyroid hormone that leads into the thyroid storm. So those are the causes. And then clinical features, mainly you will see the first we will start from the fine hair, and then hair loss will be there, exophthalmos, or you can call as a protruding eyes will be there, goiter will be there, enlarged thyroid gland will be there, and then you will get a heat intolerance. So again we told heat, we will get a byproduct of metabolism. So if there is a high thyroid hormone, means there is a higher level of metabolism. So the higher level of byproduct of your heat will produce. Because of that, heat intolerance, diaphoresis, sweating will be there, heart rate will go high, tachycardia will be there, and then cardiac failure will be there. Tachycardia, most important in cardiac system, the person will develop the arrhythmias. So in most particulate in arrhythmia, that is atrial fibrillation is one of the identifiable factor we can see in the hyperthyroidism cases. Okay. And then weight loss will be there because of the increased metabolism, increased appetite, diarrhea will be there because of the increased motility of the gut, and then oligomenorrhea will be there, that is irregular menstrual period, and then fine tremors. So those are the some clinical features that we can see. So again the same thing, only high fever, sweating, mental status or CNS related agitation will be there, confusion, acute psychosis, coma, tachycardia, atrial fibrillation, heart failure, everything. So what we told that we explained in the picture. Investigation, how it will be, so there is a key factor is your TSH. Because of that increased thyroid hormone level, your body will suppress the stimulating hormone, thyroid stimulating hormone. So there will be a decreased TSH level. If you, furtherly if you want to rule out, means you can check the T3 T4 level, that will be in a increased state. And then hyperglycemia we told, right, because of the increased metabolism and then catecholamine stimulation. So you have to work up with the glucose related things, postprandial fasting blood sugar. Is there any other cause for the hyperglycemia and all, we have to work for that, will happen in the in-hospital. Thyroid ultrasound also we can do, color flow Doppler also we can do, thyroid that iodine update test. So that part also last time we explained, that also we can go for. So then next is how we are going to manage this hyperthyroidism. So first we'll tell regarding the pre-hospital related things. So focus on pre-hospital. What are the challenges we have in a pre-hospital? First thing, mental status. So again, mental status and then airway threats. So if the person is awake and alert, means so he is conscious oriented with you, means you have to frequently reassess. If the person is in extreme state, if the person is unconscious coma state, means definitely you have to go with an definitive airway. And then if the person is only responding with the voice and then pain, means you have to anticipate the airway threat, thereby you have to manage the, or you have to control the airway with an airway agents, or you have to go with an definitive airway depending upon the condition of the person. So that is the first thing. Second thing, in hyperthyroidism we will have a hyperthermia. Because of the increased metabolic rate, we will have a hyperthermia. So how we are going to manage, means first thing, you have to give some drugs regarding NSAIDs, you have to administer paracetamol, those are the things. So still if the person have hyperthermia, means then you will go with an active cooling measures, like you can go with an something like a depit sponging. So those are the things you can take for the temperature related things. Third thing what we have means atrial fibrillation related things. So atrial fibrillation management is one of the most important thing in the hyperthyroidism management. So in what is the problem in the atrial fibrillation? What are the problem will arise? So because of that atrial fibrillation, in atrial fibrillation there won't be any adequate contraction of the atria will be there. So there won't be any adequate contraction. Because of that, that whatever blood that is in the atrium, that will stagnant, right? Because of that stagnant, what will happen if the blood is stagnant in one area, there is a formation of thromboembolism, or there is a formation of embolism. if the embolism will travel into the pulmonary circulation, means there is a condition, it's called pulmonary emboli. So in the pulmonary emboli, the person will develop the cardiac, suddenly the person may get into the cardiac arrest or hypoxemia related things. So if sometimes if your emboli gets enter into your coronary circulation, means it can lead to the myocardial infarction, acute coronary syndrome, whatever it is. And then if it is gets enter into your like coronary, means your things regarding the cerebral circulation related things, means there it can leads to the acute coronary, acute your stroke related things. Then again if get enter into your systemic circulation, means based on the area it can lead to the ischemic related things. So thromboembolism is one of the most important risk factor that will arise in the atrial fibrillation. So we have to manage the atrial fibrillation in pre-hospital, or if you found, means then and there you have to manage. That will comes under the both pre-hospital and then in-hospital management. How we can manage means based on the American Heart Association protocol, we have to first check whether the person have a atrial fibrillation or not. So how you will know whether the person have a atrial fibrillation means, first criteria, you won't see any P wave, there will be a fibrillation. So the P wave is replaced by your fibrillatory waves. Second thing, there will be a irregular RR interval. So irregular RR interval will be there. Both by seeing this both things, you can conclude the person have a atrial fibrillation. And then how we are going to manage means atrial fibrillation people. So after diagnosing atrial fibrillation, you have to categorize the people into the two category. First thing, stable case. Second thing, unstable case. How we are defining means, if the person have a hypotension or any acute altered mental status or any heart failure related signs, or if the person have any ischemia related, hypoxia related things. So those are the things indicates the unstable cases. So in if you found any instability, so if you found any hypotension or altered mental status, hypoxia related, or if the person have any heart failure related signs is there, means straight away you are going with an cardioversion. Okay, you have to consider the sedation and then you have to do the cardioversion. But if the person is stable, so there is not any hypotension, there is not any acute altered mental status, completely the person is stable, means there we are going something like a rate controlling drugs like beta blockers or calcium channel blockers. So those are the some ideal choice for the rate controlling related drugs. So this is the way we are going to treat the atrial fibrillation. So and then one more important thing, there is a digoxin. So digoxin mainly in pre-hospital we won't use as much as, but in hospital mainly we are practicing that digoxin. So digoxin how we have to give means, so there will be an ideal dose of 8 to 12 micrograms per kg. So it is an ideal dose. Maximum you can go up to 1.5 mg. Okay, here 8 to 12 micrograms per kg. Maximum dose is a 1.5 mg for 24 hours. So in one day you have to give only 1.5 mg. If you are exceeding means, that will leads to the digoxin toxicity related things. So this is 8 to 12 micrograms per kg and then maximum is a 1.5 mg for 24 hours. So again, so in this, if you are getting a value of, so based on the kg calculation, if you are getting 1 mg means, in this 1 mg 50% you have to give as a loading dose. Okay, 50% you have to give means, in 1 mg 0.5 mg you have to give as a loading dose. Remaining 0.5 mg you have to divide into two doses and then you have to administer every 4 to 8 8 hourly in a 2 times, means 0.5 mg you have to divide into 2 doses, means 0.25 and then 0.25 mg. So that 0.25 mg you have to administer in this interval of 4 to 8 hour interval, you can administer 2 doses. So that is the way you have to give the digoxin. So 8 to 12 mcg per kg, maximum is 1.5. Half of the dose you have to give loading dose and then half of the dose again you have to divide it into 2 doses and then you have to administer in the interval of 4 to 8 hours. So 2 times you have to administer. So this is the regarding the digoxin related things in the management of atrial fibrillation. And then so what are the things we told in the pre-hospital? Mental status related things, temperature related things, and then we told regarding the atrial fibrillation management, and then digoxin administration. So these are the things will comes under the pre-hospital. In hospital ways, what are the things we have to remember means the one important two important things. First thing, we have to reduce the secretion of your thyroid hormone. That is the first thing. We have to suppress the secretion. That will drugs, we will give drugs like a anti-thyroid drugs like a propyl thiouracil or methimazole, carbimazole. So those are the drug of choices. And then one more important thing, that is the first step. Second step, we have to control the circulating thyroid hormone. So that is the second step of management. Their ideal choice of drug is your beta blockers. Beta blockers is ideal choice. You can go with a calcium channel blocker also. So if you want to control the rate means either you can go with an calcium channel blockers. Again, if the person have any contraindication in beta blockers, means if the person have any asthma, those are the things means there you can ideally you can go with a calcium channel blockers. So this is the way. Two things. First one, you have to control or you have to suppress the thyroid secretion. Second thing, circulating thyroid hormone you have to manage. So those are the two things. First thing, to suppress we have anti-thyroid drugs, that is propyl thiouracil. Second thing, to circulating thyroid hormone we are giving the beta blockers. If beta blockers is contraindicated, we are going with that your calcium channel blockers. So those are the propyl thiouracil. We will give a 600 mg of loading dose, and then every 6th hourly we will administer the 200 to 300 mg. So again, this is the core management set, medical management. So we told regarding the symptoms, and then we have control the secretion, that is anti-thyroid drugs, or else we have a radioactive iodine update things. Radioactive iodine therapy also is there, or else we can go with an surgery. So if the hyperthyroidism is not subsiding within medical treatment means, then you can go with a surgery part. Either you can go with an subtotal or total thyroidectomy, or partial or total thyroidectomy. So main indication, thyroid carcinoma, or if any hyperthyroidism that is not controlled by your medical treatment means, there also you can go with an thyroidectomy. Very enlarged thyroid gland, that is because of this it is compromising your airway means, that you can go with an thyroidectomy, partial or total thyroidectomy. So these are the things regarding the management of the hyperthyroidism. So do your best, Salo.